Hey folks, Professor Finn here, and today we're going to be looking at Chapter 2 of the 6th edition of Embalming History, Theory, and Practice by Sharon Gee-Mascarello. So let's go ahead and dive into this. Embalming is both a science and an art. It is the applied chemical process concerned with sanitation and the temporary preservation of the dead body. Embalming is also a restorative process. The restoration focuses on creating and maintaining the acceptable natural appearance of the deceased. People all too often tend to think that we're just going to chemically preserve you and then we worry about your color and stuff like that with restorative art externally only. And the truth is, this is what separates great embalmers from good embalmers. Great embalmers understand proper concentrations and dye blending to get very natural colors. So then we move on to the second portion, the restoration, the restorative art, if you will, portion of what we do. Most of the work is already done. The largest complaint most families have with professionally prepared bodies is the overuse of cosmetics. And by utilizing proper dyes, by utilizing good choice and chemical selection and proper concentrations, you're going to eliminate the need for lots of dye or lots of cosmetics afterwards. Both elements are combined with stabilizing the body and suspend further putrefactive changes. It is this temporary preservation that enables us to hold the body in this condition until final disposition. Slowing the progression of post-mortem changes purchases time so that the living can make substantive final decisions. Planning and preparation requires time. If we don't have the time to make all the necessary decisions, things get rushed, people get left out, feelings get hurt, inconveniences happen. And that can be taken out on the funeral professional. From our standpoint, we need time to make sure that we are preparing this body in the appropriate manner and doing the appropriate aftercare so that the family has the best possible experience. Embalming for the anatomical study of the dead human body, for medical research, and for attaining competency in clinical skills is essential to the advancement of medical science. Some of you by now have probably already taken your History of Funeral Service course or History of Embalming, depending on what your school calls it. You may recall in any course like that, until we established proper embalming, cadaver use was extremely limited. When cadavers did get brought to an anatomical board or an anatomical hospital or a college, well, if it wasn't limited by the church, it was limited by the time you had to get it done before it just smelled so bad you didn't want to work with it anymore. And about the time we start establishing scientific research and vehicles by which we can get cadavers for scientific research, we're also leaping forward with embalming technology. Virtual methods reproduce human anatomy with accuracy. Virtual reality is an impressive and effective substitution. And there is a variety of very expensive technology out there that is happy to give you virtual human bodies. A true, complete reproduction of an actual human body defies replication. We have some firms that are coming close. Some of you may be familiar with a product called Syndaver. Well, it has its limitations. So what you see here, we have guts, we have large arteries, we might have nerves, we have veins. The problem is, it is not a dead human body. And so we cannot do things to this like we would do on an actual human body without damaging this product and possibly destroying it. This means you're not getting a good clinical experience or traditional experience working on something like this. It gives you an idea, but nothing really beats the real thing. Decomposition is defined as the separation of compounds into simpler substances by the action of microbial enzymes and or autolytic enzymes. Decomposition begins at death. Embalming inhibits the cycle of decomposition. The length of time a body will remain preserved and recognizable is dependent on a bunch of factors, both within and outside of the body. So intrinsic factors, those from within the body, include pathologic processes, circulatory conditions, body moisture, the distribution and effectiveness of the preservative chemical, lots and lots of factors. Extrinsic factors, those outside of the body, include the type of preservative used, strength and volume of the embalming solution, environmental factors surrounding the interment or entombment, the amount of moisture, molds, bacteria, vermin, the circulation of air. All of these things have to come together, and you as a funeral professional need to be able to understand all the conditions and react accordingly. Under ideal conditions, embalming may be so thorough and effective that recognition of the face is possible many, many years later. Conversely, under unfavorable conditions, the exact opposite is also true. The preservation may be as brief as a few days, at best. Variables too numerous to count prevent assurances regarding the degree or length of time that preservation of the embalmed body can be maintained. This is also going to be discussed with you in your mortuary law courses. We cannot give promises as to how long or how good something really comes down to. Our skill as embalmers only gets us so far. We have to be able to read in what type of things the body is telling us and also understand the environment we are in order to effectively keep that body as long as possible. Embalming preservatives and germicides interact primarily with body proteins, and the colloidal nature of the protein changes by establishing many cross-linkages that were not formerly present between adjacent proteins. So, I've got lectures on YouTube about organic chemistry, and the hallmark of organic chemistry is small changes equal large differences. By establishing these cross-linkages with our formaldehyde, we're changing very small components, chemically, of what is happening in the body. But because we're doing that, we change the entire way the protein reacts with its environment. It is no longer going to be as susceptible to decomposition. The chemicals and the proteins combine to form a lattice work of inert, firm material that can no longer be easily broken down by bacterial or autolytic body enzymes. This is known as embalmed tissue. Body proteins have many reactive centers and a great affinity to hold water. Embalming destroys these reactive centers, and the new protein-like substance no longer has the ability to retain water. As a result, the new embalmed protein structures are more stable and longer lasting. Thus, the tissues are temporarily preserved. The inability of the embalmed tissue to hold water results in dryness to the embalmed tissue. Enzymes have the ability to react with body's proteins, fats, and carbohydrates. Enzymes caused by the decomposition of these body substrates, or enzymes are cause the decomposition of these body substrates. Enzymes are proteins, and some people might say they are fragments of proteins, but moral of the story is they are made from the same thing proteins are. They originate either from the body cells themselves, because the body cells have to have a way to tear down larger structures into simpler components so they can rearrange them, or they're coming from the bacteria in the body. If they originate from the body, they're called autolytic enzymes. Chemicals, such as germicides and preservatives in embalming fluids, inactivate the body's enzymes. The same chemicals also destroy bacteria through reactions with the proteins that are part of these organisms. Formaldehyde does not discriminate against living or dead protein. If it sees protein, it is going to react, which is why it is such a toxic chemical that if it reacts with the proteins of microorganisms, it is killing them as it preserves them, essentially. The likelihood of the body remaining a source of disease producing microbes or their products is greatly reduced by this disinfection. Through conversion or inactivation of protein of the tissues, proteins of the enzymes, and proteins of the microbes, the body is sanitized and temporarily preserved. The degree of preservation depends on the number of contacts made between the preservative chemicals and the proteins of the body and bacteria. We've just seen that there is lots and lots of places for contact to be made. The more effective and the more thorough that the formaldehyde goes in and reacts with those protein centers, the less the protein remains normal. A normal protein will very quickly, under the right conditions, decompose. So the more of those places that we can get the formaldehyde into to react, the less normal protein remains. Hence, the more effective that the preservation is going to be. Restoration of the deceased to an acceptable appearance is also a function of embalming. It is not just limited to restorative art. Restoration is not intended to reproduce life, but rather to lessen the effect of illness, trauma, all these other factors that occur after death or just prior to death. True, some people have an excellent skill to make people look like they're taking a nap. The problem is this can feed into death-defying. People need to understand that someone is dead, and the best way for them to recognize that is for a person to look good in death. Long-term illnesses and diseases, extended drug therapy, surgeries, tumors, all sorts of things can all adversely affect appearance. An injection of the proper embalming chemicals can restore the contour of facial features. It can decrease facial swelling. It can remove intravascular discolorations. It can reduce the appearance of extravascular discolorations. And it can restore natural facial complexion. Professor Charles Donow's explanation of embalming is as thorough of a definition of the process as can be found. There are 4 classifications of embalming. Temporary preservation, sanitation, and restoration are most effective when all these embalming treatments, all these classifications are used in combination. Arterial embalming, also known as vascular embalming, also known as capillary embalming. Cavity embalming, number 2, hypodermic or subcuticular embalming, and surface embalming. A lot of practitioners will refer to surface embalming, and they include in that blanket umbrella statement hypodermic as well as other topical treatments. Arterial embalming utilizes the blood vascular system to deliver preservative solutions to all areas of the body at once. The chemical solutions circulate through the blood vascular system and make contact with the tissues and cells of the body. Embalming solution is customarily delivered by a motorized embalming machine. An instrument called an arterial tube is attached to the hosing of the machine, and the arterial tube is then placed into an artery. The solution in the machine replaces the blood in the vascular system. This is done through a process called displacement. We'll talk more about that later. The second stage, cavity embalming, is the direct treatment of the contents of the 3 body cavities: the thorax, or your chest, the abdominal cavity, kind of where your guts and stomach are, and finally the pelvis, or the pelvic cavity, as well as the lumina of the hollow viscera. Cavity embalming is applied in 2 phases: aspiration of the cavity contents and then injection of undiluted cavity fluid. Both aspiration and injection are accomplished by an instrument called a trocar. Cavity embalming routinely follows arterial embalming for common sense reasons, but later on we'll talk about why that is. And there may be even exceptions when you might want to do cavity embalming first, and we will absolutely talk about those exceptions later on in the course. Hypodermic embalming is the subcuticular injection of embalming chemicals directly into the tissues using a hypodermic syringe, a needle, or a hypovalve trocar. Hypodermic embalming is considered a supplemental embalming procedure. Surface embalming is the preservation of tissues by direct contact. Preservative chemicals are applied to a cotton compress or inlay that makes contact with the tissues, or the chemicals applied directly to the skin surface. Surface embalming is also considered a supplemental embalming procedure. So remember that I said that sometimes people refer to surface embalming as both hypodermic and this? The proper term to cover both of those topics is supplemental embalming. The primary mechanism in arterial embalming involves the replacement of bodily fluids with embalming fluids. Arterial embalming of the average adult body is essentially the injection of several gallons of preservative solution under pressure into the circulatory system through a large artery such as the common carotid or the femoral. Blood and tissue fluids are concurrently removed to create room for the preserved solution from a large vein. The internal jugular vein is customarily selected as the primary source of blood drainage. Now, there are a lot of opinions as to what is the best vein for drainage. Some people will select the carotid, some people will use a femoral, some people will use direct heart drainage, but largely, the internal jugular vein is selected as a primary source of blood drainage. It is closest to the center of drainage. We'll be talking about that later in the course, and there are good reasons why we should be using it rather than other places. The selection of embalming vessels is determined by a process used to evaluate post-mortem body conditions called the embalming analysis. The preservative solution flows through the arterial, capillary, and venous routes similar to blood circulation in a living body. The basic difference is that the embalming solution does not pass through the chambers of the heart in the same way that it does in a living body. Instead, when the solution reaches the ascending aorta, it places pressure against the aortic semilunar valves and forces them to close. This causes the ascending aorta, arch of the aorta, and the entire aorta to fill with the preservative solution and flow into the numerous branches of the circulatory system. So let's see what it's talking about here. Right here is, well, a little bit higher. Right up here is about where we usually start our injections in the right common carotid. As we start injecting down, it'll start to flow into the arch of the aorta. It'll start coming over here. And what will happen is it will start to want to flow into the heart. Your heart is engineered to stop the backflow. This is a bad thing when you have what's called valvular insufficiency. When this valve properly closes, what ends up happening is then the fluid seeks paths of least resistance, and it starts going everywhere else. And that is what we rely on as embalmers, filling all this up so that it goes in all the other directions it needs to be going to sufficiently preserve the body. The capillary is the simplest division of the blood vascular system. It's the structural mediator through which the injected preservative chemicals are delivered to the receptive tissue sites. This is where we derive the name capillary embalming. Capillaries are simple tubes that connect the terminal arterioles and venules. Capillary walls are composed of a single layer of endothelial cells. They have an average diameter of 7 to 9 microns. The surface area of the capillary network in the human body approaches a heck of a lot of length. This is about, if you were to take all this stuff out, it's about 1.5 acres and is the permeable barrier that controls the delivery of preserving and disinfecting chemicals to deep and superficial body tissues. This is the way all of your tissues get nutrients. As stuff flows into your arterioles, it has to come into an area where stuff can come out and drop things off into the tissues. If it didn't, the tissues around it would die. So what ends up happening is your capillaries, as you see in this picture here, look like a hose that has holes in it. And what this allows is this lawn sprinkling effect In life, it'll be active and passive processes. In what we do, it's passive only for nutrients, and in our case, preservative, to flow into the tissues. The circulatory system of humans contains approximately 5 to 6 quarts of blood, or 8% of all body weight. Nearly 85% of blood is contained within the capillaries. Through perfusion of the soft tissue sites with appropriate concentrations of injection chemicals involves far more than just filling the aorta and its primary branches. Making little notes to myself as we go through for some of these corrections, because voice recognition is not that smart. A portion of the embalming solution passes through the capillaries and enters the tissue spaces. At the tissue level, the preservative solution makes contact with the cells of the tissues and the body proteins. Cavity embalming is the second stage of embalming. Many organs of the body are hollow, and their contents are not reached by the preservative solutions vascularly. Fancy way of saying there's a lot of space for stuff to go in, and not all of it gets where you need it to go. Also, there are limitations. Your capillaries don't leak into your intestines, so anything actually inside of your intestine that maybe you were digesting from that last meal is not going to be affected by that vascular preservative. The contents of these hollow organs must be removed to make room for the introduction of cavity fluid. This process is called aspiration. The trocar is inserted through the abdominal wall near the umbilicus, or the belly button, and the trocar pierces these organs to withdraw the contents, and then it also penetrates the solid organs in order to allow the cavity chemical to better penetrate. So we're doing two things. We are going in and we're poking holes in the very thick solid organs, your liver for instance, and then we're also poking holes and taking the contents out of hollow organs like your intestines and your stomach. Cavity aspiration also removes fluids and gases from between the organs that have accumulated prior to or after death. Gases cause pressure. Pressure pushes down on these very sensitive places, and when there is pressure, it could cause fluid not to flow you where you want it to. Remember, fluid is always going to take a path of least resistance. So if the choice is to go here where there is more pressure or go up here, it will take this route 100% of the time until this route is completely blocked, and then it will try to force its way through here. By removing the gases, we can relieve those pressures so that the flow remains constant. The same thing goes with the liquids. The liquids will cause pressure, but more importantly, liquid is a decomposition accelerant. We want to get as much excess liquid out as possible so that we can control any sort of post-mortem changes. Once the liquids, gases, and semi-solids are separated, the process of injection begins. The bottle of cavity fluid is directly attached to the trocar for injection, just as we see here in what's called an evolution injector, or it's attached to a separate thing called a cavity injector, which is attached to a hose. Now, the evolution injector is basically this handle and this trocar attached to it. There is a cavity injector right here. This is how the trocar works. On traditional trocars, this item will be attached to a hose, which then attaches to the trocar, and there'll be a little nozzle or a slip hub at the base of the handle on a traditional trocar. Evolution injectors like what you see here are only good for injection. Traditional trocars are good for aspiration and injection. The trocar is introduced into each of the aspirated and channeled organs to deliver concentrated cavity fluid. Cavity fluid is not diluted for use. You use it fresh out of the bottle. The accumulated waste products in the body cavity will dilute the cavity fluid upon contact. Now, the more that is in the body when we apply cavity chemical, the more the cavity chemical is going to react with it. Hence the necessity of removing as much of the products we don't want to preserve so that our cavity fluid is more effective. Customarily, a total of 32 to 48 ounces of cavity fluid is introduced into the three cavities, thoracic, abdominal, and pelvic. This means 2 to 3 bottles, since each bottle is 16 ounces. Certain conditions necessitate reaspiration of the cavities and re-injection of cavity fluid. People try to cut corners. Reaspiration takes a little bit of time. The reason why we reaspirate is to save further complications down the road, as well as limiting our professional liability, because we are taking proper steps to controlling the decomposition of that body. If you are thinking about not reaspirating, but you should be reaspirating. Supplemental embalming includes both hypodermic and surface embalming treatments. So hypodermic embalming is the subcuticular injection of a suitable preservative chemical directly into tissues. Trocars and needles are available in a variety of lengths and sizes or bore sizes. So you can have trocars like a cavity trocar that is fairly long. You can have very small needles. You can have 16 gauge needles, 5 gauge needles, 20 gauge needles. Depending on what it is that you are doing, you may be using very, very fine needles, which means you want to be very careful because those bend and block really easily. The area of treatment may be localized. A small bruise, maybe one finger, or it might be extensive. The entire anterior surface of the abdomen, for instance. Hypodermic treatment is employed when sufficient preservation is not achieved by arterial embalming and to perform restorative treatments such as tissue bleaching or contouring. We should not be heavily relying on supplemental hypodermic treatments to save time with vascular injection. The best preservation, the most thorough preservation occurs through vascular embalming. And then, if that is unsuccessful, or it is not as successful as we would have liked, then we will employ these other treatments in tandem to that. Surface embalming is the application of the embalming chemical directly to the surface of the tissues. Embalming chemicals are applied as a spray, brushed onto the surface in liquid or gel form, or applied on cotton as a surface compress. The preservative can also be applied beneath the skin in areas such as the eyelids and mouth. You will hear two terms used, compresses and inlays. The only difference between a compress versus an inlay is where you are putting the pack. If you're taking a piece of cotton, saturating with chemical, and putting it on the outside of the body, it is a compress. If you take that same compress, put it on the inside of the body, say on the inner surface of an abdominal flap on an autopsy, that is now an inlay. Inlays go inside the body. In the case of an autopsy, surface embalming of the cavity walls and beneath the cranial scalp is routine. And that is because when they make a Y incision, they are interrupting all the vascular connections on that skin. And it may be very much necessary to go in there and treat some of that. Another reason why is if, depending on the type of autopsy they're doing, in order for fluid to get to the surface of the skin, you have to have vasculature underneath it. And if they do a full post-mortem, all the major arteries that would supply those outside walls, those outside areas, are now gone. So you're going to have to rely on actual surface and hypodermic treatments in order to try to adequately preserve those areas. The process of anatomical embalming varies from the embalming customary to funeral service. In general, cavity embalming is not permitted. The future doctors who might be playing with these cadavers won't appreciate it if we're poking holes in all the stuff that they're trying to find. So, hypodermic treatments should be avoided as much as possible. Hypodermic treatments by needle and syringe exclusive to facial features and fingertips and surface embalming treatments are allowed. Puncturing a little bit of the skin, not much of a concern. Poking holes in organs and other things, that's problematic. Anatomical donation, which we'll discuss later in the course as well as in mortuary law, requires legal documentation for the donation. Bequeathal of the body or giving by will after death is considered a will and is legally binding. Body donation is considered a final disposition for legal certification and associated transit permits. Customarily, body donation terminates in cremation. In the modern practice, usually the bodies are actually cremated with flame. There are some markets, some jurisdictions that will use, say, alkaline hydrolysis, also known as resumation or water cremation, to dispose of anatomical cadavers. The time of use for a cadaver spans up to 2 years. Embalming for long-term preservation of the body takes precedence over the appearance of the body. I've been present when people have done anatomical preservation. At the lab I used to work in Miami, Florida, which was a teaching lab at a funeral service program at Miami-Dade College, we did not receive, I don't think in the entire time I was there, a single body for anatomical donation. We always just did standard consumer level embalming. When you are doing anatomical embalming, disfigurement of the body will likely be required, if not outright encouraged. So it is a different type of skill set, and you will follow the instructions that they give you regarding that. That being said, families can have a funeral with a body before it goes to anatomical donation. And very clearly, you do not want to be disfiguring a body prior to visitation. So you may have to do supplemental treatments after the service is over. Very large volumes of solution, 8 to 12 gallons, are injected from a single site. Blood drainage is restricted to allow the tissues to greatly expand to create deep diffusion of the embalming solution. So what is happening there? Think about it. We just talked about the fact that our capillaries allow things to go out. With consumer level embalming, we might not have the time required to do a thorough perfusion of the entire body. It's virtually impossible. With anatomical embalming, we're going to fill that body with so much fluid that it's not going to know what to do with itself, and it's going to fill as many spaces as possible and get the most thorough possible perfusion, because the body's going to be held for 2 years. And the only way we're going to get that stuff everywhere is through pressure. Concentrated embalming formulations are commonly a mixture of formalin, phenol, alcohol, wetting agents, and EDTA. During dissection, wetting agents and other chemicals may be topically applied to prevent dehydration and mold formation. Anatomical dissection and study frequently call for cadavers that retain muscle and joint flexibility and have the feel of living tissue. Manipulation of these tissues is paramount when performing clinical skills and mock surgeries. The pliability of these specimens is integral for accuracy in teaching medicine and surgical skills. Soft embalmed cadavers do not have the longevity that traditionally embalmed cadavers do, but have very clear advantages over those same traditionally embalmed cadavers. The desired outcome is to produce overall tissue firmness without gross distension. Deliberate abdominal distension is required to completely saturate the internal organs for cadaveric research and study. Soft embalming fluid is typically formaldehyde-free, composed mainly of alcohol, phenol, and glycerin. Basically a baseline preservative, alcohol is a preservative, phenol, which is also a preservative but a disinfectant, and glycerin, which is a humectant or a wetting agent. Donors receive a total of 5 gallons used, 5 gallons including the volume used for hypodermic treatments. Injection pressure is high, 60 to 7 psi, and the rate of flow is rapid, which is a good way to swell things up, injecting under high pressure with a high rate of flow. This is usually discouraged for traditional consumer embalming. The first 2 gallons are injected from the right common carotid only. Soft embalming necessitates a 6-point injection for the most successful outcome, because if you're going to do it hard and fast, you're going to have to go to different locations and directly inject the stuff right into it. We'll talk a lot more about those type of conditions and injection theories in the appropriate chapters. All arteries are clamped during arterial and hypodermic injection to maintain intravascular pressure and to prevent fluid loss. No blood drainage is taken. Blood remains in the veins to allow easy vessel identification during the anatomical study. Hypodermic treatments utilize the fewest points of entry. Hypodermic injection by hypovalve trocar includes the abdominal wall to enhance vascular embalming without risk of damage to the internal organs. The buttocks, the lower back, shoulders, feet, and tissues surrounding the femoral injection sites, thighs, and pubic region. When we inject hard and fast like what's being described here, we know it's not going to penetrate everywhere. What do we have to do? We have to supplement the arterial injection with these other treatments. Hypodermic injection by needle and syringe is used for the fingers and toes. Vessels are ligated after embalming and the incisions are left open. The incisions are not sutured. The donor is placed under mortuary refrigeration for a period of 2 to 4 weeks to cure before first use. When we inject, the more holes we make in the body, either through cavity embalming or whatever else, the more holes we poke into arteries, the more the fluid is going to leak, and the more the fluid leaks, the less it is going to push itself out of those capillaries into tissue spaces. So we inject a large quantity, very hard, very fast. We ligate when we're done to hold as much of that pressure and fluid as possible, and it forces as much of that soft embalming fluid into the tissue spaces as possible. And by giving it 2 to 4 weeks, we are maximizing the amount of time it has to preserve. Prior to each lab session, the donor is towel dried for aesthetics and donor respect. Lab sessions are limited to a few hours. Donors remain viable for study for a period of 4 to 5 months and are refrigerated when not in use. The reason why the lab sessions have to be limited to a few hours is because when we embalm with something other than formaldehyde, we are not getting those cross-linkages. If we do not get cross-linkages, we are not changing what the tissue is. The proteins are remaining constant, which means they are susceptible to decomposition. So we take them out of refrigeration, we do what we need to do, we put them back into refrigeration so we can maximize the usage of those cadavers. Documentation is to be completed for each decedent brought into the custody of a funeral home or embalming facility. When the body is being prepared for shipment to a different location, a copy of the paperwork should accompany the remains. Now, between the previous editions of the book and the 6th edition of the book, we have a large transition to different names for forms. So there are embalming forms, there are care forms. With the 6th edition, it is important to understand that an embalming form is going to tell you how you embalm the body. A care form may tell you all the other things that was done to that body, and your book gives you examples of what these forms are and how they should be used. Your funeral home business model will dictate what you do on certain forms. The moral of the story is document everything and be consistent in documenting everything. And you never hand out originals. Select the appropriate care form based upon the nature of decedent care provided. Separate embalming reports and decedent care reports are currently available. Numerous forms are included as examples at the conclusion of the chapter. And these are not just academic forms. These are forms based on best practices used by some of the best funeral homes and care centers in the country. And they are intended to demonstrate the lengths you have taken to do your job well as to limit the liability because you have all of that documented. Decedent care reports should be filled out in detail and kept as a permanent record of the funeral home or the embalming facility. Many facilities are going to paperless environments. It is important that if you are using paper, that you back the paper up maybe digitally, and then also store your digital records securely with redundancies. The report should provide information to accurately describe the following: the condition of the body before preparation. If you do not notate how that body looked before you start working, you have no record whatsoever. You should be as thorough as possible in dictating the conditions of the body prior to preparation, and if there are concerns, you should be addressing those concerns to the proper individuals. Any post-embalming or post-care treatments. All too often, people embalm the body, finish the embalming report, and don't write anything else down. And if something goes wrong, you have no record of what you did, and you're relying on people's memories. You do not want that to be you. The date and time of arrival of the body into the custody of the funeral home or embalming facility, starting and ending times of preparation, and the full name and license number of the embalmer and others authorized to assist in the preparation. It is important to know when the body came into your building. There may be hours or even days between a point where a person was maybe taken from a residence and stored at another facility or sent to a medical examiner or coroner's office before it arrived to you. Any negative changes, if you don't notate them and you don't write when that body came in, now become your responsibility. Anyone who is in the presence of that body when it is being embalmed should be also notated. So your apprentices, your residents, your interns, whatever your state calls them. Make sure that the people who are working on that body are notated. And always make sure a fully licensed professional is there supervising if the law requires that in your jurisdiction. And the reason why I say that is because there are some jurisdictions that are swapping to general supervision versus direct supervision. With direct supervision, you must be in the room watching them. With general supervision, usually that means you can be in the building or down the hall without you directly supervising certain individuals. So be very careful. If you are a licensed professional and you are not in the room, you probably don't want to be signing a form. It's as simple as that. The licensed professional controlling that embalming should be present watching what is going on in there. Embalming and decedent care reports are a critical component of any legal proceeding alleging improper decedent care. The report is the first document requested and will be scrutinized. Documentation is essential in every circumstance without exception. Having been a person approached by both plaintiffs and defendants' attorneys, the first thing I ask for is the embalming information. I want embalming reports. The second thing I want is I need a timeline. I need anything that tells me how these things went down. And then from what you wrote on an embalming report, from a timeline I put together, I can absolutely pick apart and destroy someone for inconsistencies, or I can see that you were very thorough and did a very good job. It is A or it's B. The practice of universal precautions is applied to all decedent care activities. This means we assume the body is infected with contagious disease and all precautions should be taken. The use of personal protective equipment is applied in all decedent care activities. I have a separate video on this channel that talks about things you should be wearing under your PPEs to stay comfortable, and also some PPEs that you may wish to invest in that may be better than the average bear or better than maybe what your employer may provide you, so that you are both comfortable and safe. Confirm the identity of all bodies and maintain the identity through all phases of care. It's called a chain of custody for a reason. Compare all forms of identification on the body and body bag. Compare wristbands, funeral home records. The funeral home or embalming facility should generate and fix its own method of identification to the body. That is true. And I can tell you that most states require the funeral home to affix its own permanent identification to the body at some point in time. I am a Florida licensed funeral director and embalmer, and a funeral home or other service is required to attach its identification when the body is taken into its care. And when it is delivered to the funeral home, a best practice is the funeral home then compares the transport services tag, the hospital's tag, and then affixes their own tag so that they know that all three parties have conclusively identified it is that person. Perform periodic monitoring of the body while in the custody of the funeral facility. Make necessary adjustments to provide treatments for adverse conditions. Every time we embalm a body, it is a Hail Mary without exception. We are throwing the ball and we are hoping that it reaches someone's hands every single time. Someone may try to counter-argue, say, well, if you're really good, you will understand that sometimes the body just doesn't go the way you want it to go. And the way we find that out is through periodic monitoring, by looking at the body and making sure that the embalming is taken, that mold is not growing, that everything we assume should be going on is no longer an assumption, but is either proven true or proven false, and if false, we need to take the proper corrective action. Cover the body at all times to maintain the dignity of the deceased. Place a modesty cloth to cover the genitals during embalming and when providing decedent care. Engage the room ventilation system. Anytime we are working with the chemicals we work with, we really want to make sure that we have fresh air going into the room. Now, in some of the older funeral homes, the problem with this is that the airflow is based on having windows open. So be sure you know what you're supposed to be doing in your specific prep room, and if you must have windows open, be sure to take precautions to make sure that people aren't coming in and putting phones up against the open areas to see what's going on in there. Dispose of contaminated items such as medical waste and body bags in an approved biohazard waste container. Dispose of contaminated sharps in an approved biohazard sharps container. Now, your book has a number of forms. I'm going to highlight some of these. The embalming authorization provides permission for embalming the body and indemnification of the funeral home. Now, indemnification forms are not 100% effective, but they are a necessary first step. And if you've done your job well, you provided the necessary statements, an indemnification form goes a long way to limiting your liability at the funeral home. Now, under the Federal Trade Commission's funeral rule, under the FTC rule, you are permitted to proceed with an oral permission to embalm. But you want to check your state's definition because some states may require actual written permission before you may engage in embalming, even if you received oral permission. Be very careful when you are asked questions, whether it is under the FTC rule or they're asking you maybe under a general practice of the jurisdiction you're intending to practice in, because those things may be different. For standardized exams like the National Board exam, 99% of the time, unless they are stating something specific in the question itself, they're referring to the Federal Trade Commission's funeral rule, not a state's jurisdiction. A good embalming authorization should list the following. It should state who may assist in the embalming, such as students or licensed trainees. This may be a requirement of the jurisdiction you work in. But if you do let people come in like apprentices to work on client cadavers, the families need to know that, and they need to understand that trainees are involved. If they say, no, I don't want a trainee there, you're probably under an obligation to obey what they are telling you, since the person giving you that directive is likely the person with the right of disposition. It provides for the contract employment of a trade embalmer. Not just your employees, but other agents you may employ for these purposes. It allows the body to be embalmed at the funeral home or at a separate embalming facility. You might not have to name the facility, but you have to probably let them know that you might not do your own prep on the facility. It allows for certain restorative treatments. Now, it is very well disclosed that there is a line that when you cross, you need further permission. General, small, restorative treatments, or what we call in restorative art, minor restorative treatments. These are generally covered with an embalming authorization. When you must start doing more excessive treatments or major restorative treatments, you probably need to get an additional disclosure, and you're probably going to have to outline as politely as possible the types of things that you are doing. Embalming authorization should finally protect the funeral home if the body has been misidentified. If a family member does not want to identify the body, your embalming authorization should state that you are not held liable if your chain of custody is based on labels. Now, this does happen, that a hospital misidentifies a body. You go in to get John Doe, you pull out the body bag, it says John Doe, you open the bag, you look at the wrist, it says John Doe, you apply your bracelet to it, you write John Doe, you have John Doe. And when the Smith family comes in and says, well, that's not John Doe, that's Joe Smith, it is very important for you to have based all of this identification, or where the identification was based is on the hospital's identification. This allows you to basically put the hospital in the hot seat or other care facility that mislabeled it because it was not your fault. And if the family has declined to identify the body, they run the risk and they assume the liability that this could happen. Full disclosure and personal identification is a best practice. I know a lot of funeral homes don't do that. But having a family member or an agent of the family that knows the deceased is usually a very good way for a funeral home to limit their liability by forcing them to identify the deceased. You should have authorizations for restorative and cosmetic care. Give permission when extensive or operative restoration work may be necessary. And we'll talk more about operative procedures later in this course, as well as in restorative art. Authorization for minimum care services. This authorizes care when embalming is not requested and gives the facility permission to prepare the body for identification, viewing, or for cremation. Now, the reason why you want a separate form for this is because of the fact that if you sign off on an embalming authorization and an employee is not looking through the whole form, they might not realize the only thing they're supposed to do is bathe the body, set features, and get this body ready for a funeral home identification or an unembalmed viewing. By having a completely separate form, you are reducing your risk of miscommunication. And also it makes sure the family understands that you are not getting an embalmed body, you are getting basically a bathed body with very minimal treatment done, and the same rules of preservation do not apply for a minimally prepared body. Authorization to prepare donation cases for viewing. This form is used when a funeral facility prepares a body where organs and or tissues have been donated, because there's likely going to be an explanation on this form about the complications that arise with these type of bodies. Green funeral release and indemnification gives direction for disposition of the dead human body when a green burial or natural burial is requested, so that you are aware of exactly what it is you're going to be doing and what you are limited in doing, because we are going the green funeral route. Families need to be aware that when you choose a green funeral, there are limitations in as much as what can be done with that body, how long it can be left out, things of that nature. And they need to understand up front that you're not dealing with an embalmed body, and green funerals have certain restrictions. Identification of remains of the decedent. It verifies the identification of the decedent. Note the following. It states who was making the identification. Was it a family member? Was it an agent of the family? Who was it? Who was the body that was viewed and identified? states the next of kin or authorizing agent refuses to identify the remains but authorizes final disposition without positive identification, and indemnifies the funeral facility of the body if it is incorrectly identified. It is important that you also, especially when people choose, they refuse to make an identification, that you do take the time to explain what procedures are in place and what they are based on. So like I just explained, when you can tell a family when your loved one was taken into the hospital and admitted, they were given an identification bracelet. When our agent or our employee goes to the hospital, transfer your loved one into our care, they will verify the identity of that bracelet and all the external labeling to make sure that they have the right person. We will then apply our permanent ID band. And if you're using a transport service and comes to the funeral home, once your transport service comes there, you may even state that you further double check to make sure the transport service did the right thing by checking their permanent ID, the hospital ID band, and all the labeling on the body bag or other containers that the body is being received in. It is good for families to know that this is your process, but the process is only as good as that initial identification. If they have the wrong bracelet on the wrong person, everything fails as a result of that. Trauma viewing without embalming. Used by the funeral home when they want to advise against viewing the body due to severe conditions, but the family wishes to view. This is a very important form. And when you are filling out this form, the worst thing you can possibly do on earth is sugarcoat something. You must explain in clinical and in plain English what this family is going to encounter. They need to make an educated decision as to what they are going to be seeing, and they need to understand that this is going to cause them potential trauma. There is no business in sugarcoating these details. The way I would handle this is I would say it in clinical words first, and then I would translate them into plain English. This form must be completed in our decedent care report. This form must be completed in lieu of an embalming report for each deceased human body brought into the care of a funeral or embalming facility. When we say every body gets documented every time, we are not meaning just the people who are being embalmed. When a body comes into our care, we look at every body, whether it's being embalmed or not, whether it is a traditional or direct cremation we already know about, and we notate the condition of the body, any personal effects, etc. If you don't document it, it's not done. It's as simple as that. If you don't document they were in good condition when they were received and they turn purple and brown and nasty, then it's on you. If they came in purple, brown, and nasty and you didn't document it, then they were received in ideal conditions because you didn't document something different. Both are going to require research. But the one that will be easier for you to figure out and say, hey, it wasn't our fault, something must have happened, is the one where you documented the condition of that body when it came in, and then what failed going forward. Did you improperly store the body? Did you try to get the head up like you should when any body comes in? Whether or not they're going to embalm or not, you might want to put something under the head in the event they change their mind. A copy of this report should accompany the body being shipped or transported. And if you have an embalming report, that should also be included. An embalming report must be completed for each deceased human being brought into the facility for a purpose of embalming. That means you have a form, a decedent care report when the body is received, and at the time you begin embalming, you also then have an embalming report stating what was the condition of that body at the time of the embalming. That permission might be received an hour later, maybe a week later, days later. You want to be able to categorize any changes in the body so that you have an accurate idea of what's going on. If the body came in good and you raise the head up and 2 days later you got permission to embalm and you take the body out of refrigerated storage and you look and you see that the face is starting to turn dark purple and that there are complications in the head, you know that there is something wrong that's going to require your utmost skill to figure out what's happening there. Could be a blockage in a vein, could be a pathologic infection that's causing rapid decomposition. You're going to have to figure out what's happening there, and you are 100% likely going to be doing something different to the head than the rest of the body if this is starting to rapidly decompose and everything else is fine. A copy of this report must accompany the body being shipped or transported. Again, a care report and an embalming report for every embalmed body being shipped or transported. And the last one is an attention funeral director. It's a form for bodies being shipped to another facility. It describes the condition of the body at the shipping location and requests notification of any problems. It is to be accompanied by a copy of the decedent care report. If the body's been embalmed, a copy of the embalming report should also be included. This is a courtesy cover letter, essentially. At the time the embalming was done, before you may embalm the body, and you may have 3 or 4 days before shipping. Right before you go ahead and place it in the appropriate shipping container, you may review it one more time. You notate the condition of the body at time of placement, and that's the cover sheet. Then they also have your supporting documentation of the way the body was received, as well as the embalming form at the time the body was prepared and all the treatments that you have done to that body. So folks, thanks for sticking around to the end of the lecture. We'll see you in the next video.